I'm a CF nurse. I'm not a doctor. I work in Belgium in the University Hospital in Leuven, and I'm a CF nurse for adult patients. So I'm here to talk to you about what measurements we can take to prevent cross-infection in CF patients. And of course it's all about the germs and how we can classify patients and segregate them from each other according to the germs they are colonized with. And then we are going to talk about the transmission of the germs and how we can prevent infections, cross-infections, and what the impact is on the patient and the family with these measurements. Dr. Knoop already showed you this slide where you can see that there are a lot of germs that our patients harbor, and as you can see, when patients are younger, we see that Staphylococcus aureus is the most common bacteria patients are colonized with. And when they grow older, Pseudomonas aeruginosa is the most common one. But as you also can see, there are a lot of other germs that these patients harbor. So therefore, there is some classification. And as you can see, like group 1 are the patients who doesn't harbor germs or are colonized with Staphylococcus aureus. Group 2 are the patients with Pseudomonas aeruginosa. Group 3 are the patients with the multi-resistant Pseudomonas aeruginosa. Group 4 are patients with Bruchoderia cepacia. Group 5 are the patients with methicillin-resistant Staphylococcus aureus. And group 6 are the Agromobacter xylosoxidans patients. So these groups are very important for us when we see patients in the clinic. Now we are going to talk about the transmission. We have this direct contact with the infectious secretions of the patients, especially the sputum. And when seeing each other, it's always the saliva droplets that comes from one person to another that can infect the other person. It's not only in CF patients, it's everybody who has a cold, everybody who feels sick can transfer these germs like that. But for CF patients, of course, it's a very important thing to keep a distance from each other. The other way is the indirect contact, or the contact with contaminated objects. And the most common thing in the hospital are the nurses of all healthcare professionals that are working. They touch about everything, like the nuts of the lifts, doors, doorknobs, tables, chairs, even simple things. But all these objects can be contaminated. And also the equipment we use, oximeters, blood pressure meters, all these things can be contaminated. So the recommendations from the CF Foundation are very strict. They start with educating everybody about cross-infection, especially all healthcare workers working with cystic fibrosis patients, but also the patients themselves, their parents and their families. And although strategies are almost in every hospital implied, it is the responsibility of the CF team to see to it that healthcare workers working with CF patients adhere to these strategies, as well as patients themselves. And we also have to take contact precautions so that patients with different bacteria don't meet each other, and therefore we segregate patients from one another. So all starts with hand hygiene, especially in the healthcare workers, and we cannot repeat this enough. So we should at least wash our hands or disinfect our hands before and when leaving a patient's room or an exam room. Before and after every direct contact with a patient, with secretions like sputum, or with body fluids like blood, urine, or stools. We should wash or disinfect our hands after contact with all possible contaminated objects. During outpatient clinic, we must segregate patients according to the groups we just mentioned before. And the recommendation is that each patient should be placed in an exam room at arrival at the hospital, and that the pulmonary function test should be performed in this exam room, and that all members of the SCF team rotate through the room, so that the responsibility for the hygiene is not in the patient, but is in all healthcare workers seeing the patient. And after the patient has left the room should be cleaned and disinfected in between patients coming to the exam room. Now, these are ideal situations, and I must admit that even in our hospital, this is not possible because we don't have enough exam rooms to imply this. What we do is seeing patients and disinfect all surfaces in between the patient when he comes to the room. While the patient is hospitalized, he should be treated in a single room and not in a double room or with other patients in the room. Also, the patient should use hand hygiene before leaving his room and wear a mask when leaving this room. All patients should wear a mask when entering the hospital, and patients hospitalized can take this mask off, of course, when they are in their own room. Respiratory interventions should be performed in the patient's room and not elsewhere, because all the germs would be spread in other rooms this way. And of course, a single use of all the area clearing devices is necessary. In our hospital, we advise our patients to bring their own nebulizer with them. It's not only the best way to prevent cross-infection, but it's only a good manner to have a look at the nebulizer, how he is still working, how old he is, and also look at how he is treated by the patient and how he is maintained. And of course, patients should not have contact with each other while hospitalized. Patients in our hospital are not, should not enter each other's rooms, and should also always keep a distance when they know each other and when they meet each other in the hospital. About the equipment, and especially the different nebulizers, we always advise patients to rinse all parts under running hot water separately when they have used their nebulizer, and if possible, when there is some mucus sticking to the nebulizer parts, they should brush it with a soft toothbrush. Then they should dry all parts and keep all the parts in a dry place. And we advise patients to boil and disinfect all nebulizers parts at least daily. For the daily life of the patients at home, we advise them that they should wash their hands regularly. They should cover their cough and sneeze with their hands. They should not share personal items, like not drinking from the same glass of water with someone else. They should not shake hands with people. And they are advised to inform their school or workplace that they have cystic fibrosis, and they have to obey to some hygiene measurements. It's much easier for them to imply them when everybody around them is familiar with it. And we advise patients to have this yearly flu vaccination. And of course, to keep a safe distance from others with CF. So all these measurements have a huge impact on the patient's daily life. And it is our experience that we see a lot of anxiety in patients, and especially also in parents of young children, when they are going to school, like in a winter day, when there is a lot of flu, a lot of sneezing around in the school. They don't like to go to have their children going to school, or CF patients going to work. It's often difficult when they meet sick friends. They cannot attend appointments with sick friends, or going to a toilet in a strange place when the toilet is dirty. is also a difficult thing. It's often also a problem in schools and in working places. Or even just taking the bus is difficult when you have a bus loaded with people and you should keep distance from someone else. It's not possible when you have to use this transport. So we see sometimes obsessive people, mothers cleaning very much or too much, disinfecting their house, and even not allowing visitors in their house. And we should help them and support them with dealing with these extremes also. And there are some other things also, like siblings with CF harboring different germs. What do you do when two people with CF living in the same house and have different germs? They use the same bathroom, they use the same kitchen. So this is often difficult in a family. Or even falling in love with a CF friend when you have CF. How do you do that? What do you do with it when you have different germs? So these are often difficult things to deal with. But on the other hand, we have also patients who are careless, who don't mind having bacteria, who don't mind transmitting their bacteria to one another. So it is also our task to help these people to follow the recommendations. But in the end, although patients harbor different bacteria, we should not stigmatize them. They are always people. They are not only someone with a bacteria. We should keep that in mind every time we deal with it. Thank you.
Are there any questions on home IV treatment, intravenous antibiotic treatment? Thank you.
This is somewhat different from what we talked about before, but it's something we do in Belgium since about 15 years. That is giving people with CF the chance to do their treatment, IV treatment at home. So from the previous speakers, we know that our patients harbor pathogens, sometimes multi-resistant pathogens, and these pathogens cause exacerbations in patients with hemoptyria. And then the doctor can decide to give the patient IV treatment with antibiotics. And the next thing people ask then is, why can't I do this at home? But there are some things we should consider when patients want to do their IV treatment at home, and that is the choice of the venous access, the choice for the antibiotics, when and how to decide whether a patient can go home with IV treatment. And then I will talk about how we teach our patients and how we do it in our center. The first thing is the choice of the IV access. We have three types of IV access, like the peripheral inserted catheter, the most common one. We have the peripheral inserted central catheter, or the PICC line. That is a PICC line that is placed in a deeper vein in the upper arm, and the catheter ends in a big vein near the heart. A midline is a catheter likewise, but he's shorter. Yeah. So the PICC line ends here, and the midline ends normally about here. And the third possibility is a totally implanted venous access device, port catheter. So the choice for the IV access is given by the frequency of the need of IV treatment in one person and what the venous possibilities are in this patient. For the peripheral inserted catheter, we know that it is easy to place and that it is cheap, but that it is difficult to place in patients with difficult access veins, and these catheters are not foolproof. So we don't recommend using these catheters in patients who go home with IV treatment. Peaks and midlines, we know they are foolproof and they are comfortable for the patient to use. But when these catheters are placed frequently, they can damage the vein wall, and in the end, they can cause occlusions in the vein. These catheters are also expensive to place because they have to be placed under ultrasound. We use these catheters in patients who do not have a high need for IV treatment and who have very difficult veins, peripheral veins. And not frequent, I mean 1 time a year or less for the IV treatment. When patients are in high need for IV treatment and they need antibiotics frequent, like 3-4 times a year, we always advise patients to have a TVAD placed. These are foolproof, they are easy to access, but the other thing is that they still stay a foreign body, and they are of course invasive to place. And the difficulty for these catheters is when people don't use their TVAD often, they need flushing when they are not in use every 12 weeks. And of course there is the visibility of this catheter. They are almost always placed on the chest wall, and certainly in skinny patients it is very visible. So taking into account that patients need IV treatment frequently, we advise patients to not go home when they have IV treatment only once, twice a year or less. We must be sure that they have a good venous access before they go home. And we must be sure that patients have the right knowledge and the competence of IV treatment, they or a carer who is at home with them. And sometimes we must consider that exacerbation is not only an antibiotic deficiency. Sometimes exacerbation is also caused by non-adherence. And in this case, we don't advise patients to go home with IV treatment, because we want to see the patient over some time and have the possibility to talk to them. And then of course we should consider the benefit of home therapy against the burden of doing all these things at home during at least 10 days. The decision for home therapy is always made by the doctor in accordance with the CF nurse, the nurses on the ward, and of course the patient. And for some patients, it is necessary to have a community nurse available so they can have someone to rely on when they are at home. So how we do it in our center, we developed a brochure for the patients in which we explain with photos, step by step, all steps that need to be taken to solve the antibiotic and to administer it. So this brochure contains general information about hygiene, about antibiotics, about the different medicines, about the time schedule that needs to be followed for giving antibiotics. And then we have items like solving an antibiotic with a transfer needle, solving an antibiotic with a needle and a syringe, preparing for a liquid antibiotic, inserting an infusion line into an infusion bag, the use of an IV pump system for continuous infusion, and how to administer antibiotics by a peripheral catheter, a PICC line and a midline, and by TVADs. And of course there is a section problems and solutions in which the patient is educated in what he can do himself and when to contact the CF nurse. So together with this brochure, we have a small computer program that the ward nurses use to educate patients. And in this program, the nurse, step by step, can tick off if the patient has understood the step or not, or partially, or he did understand it completely, and then there is a section to add some information, like this is, he didn't understand, he did understand partially, he did understand completely, and then the nurse can here add some comments. So the nurse uses this to teach the patient, and when her shift is done, the next nurse can go on with this program and see where the other nurse has left it and what should be repeated with the patient. And after 4 days, there is an evaluation with the doctor and with the CF nurse how the patient is doing and if the patient is ready to do this at home. This is what we do when we start up with patients. When patients come to the hospital regularly for IV treatment, we have this need to evaluate their knowledge repeatedly, because sometimes people just forget. They lose some of the information. We need to evaluate if the time schedule, they still know how important the time schedule of giving antibiotics is. And we need to evaluate the competence of the patient in doing it practically with every IV treatment. And of course, we need to evaluate the patient's motivation for home IV. So when patients come to the hospital and they are very tired, they have many symptoms, they are very feverish, and they still want to go home after 3 days and doing it at home, we advised against it. We should have them for a longer period of time so that the doctor has the time to observe these patients better. So it's good to evaluate the motivation every time again. This is how we do it in our center. We hospitalize patients always for at least 3 days. In these 3 days, we prepare the discharge of the patient, we order the medication, and we order materials at a home care company. We work together with a home care company. They have nurses, they have materials, and they provide in the hospital all the materials the patients need for his home therapy, like needles, syringes, disinfectant. All these things are provided for by the company. And then in Belgium, fortunately, we have this reimbursement for medication and materials for patients who do their treatment at home. And after 10 days of home treatment, patients come to the outpatient clinic to evaluate how they are doing. The hospital pharmacy provides the medication. The home care company provides the materials. After 7 days, the nurse from the home care company visits the patient at home. He or she does a blood draw for the aminoglycoside level. They take the vital signs, blood pressure, oximeter, pulsations. They control the IV access, and they perform a pulmonary function test with the patient. After this home visit, they make a report, and they send this report by mail to the CF nurse. She reads it, she controls the blood levels of the patient, and she follows up if there are problems. So that was